Hello and welcome to Let's Medicine. Today the topic of discussion is diabetic gastroparesis. So what about it? Normally, the distension of the stomach and intestine is the most important stimulant for motility. But in gastroparesis, there is a neuropathy that leads to the dysmotility in the form of inability to sense the stretch in the GI tract. So this neuropathy leads to the delayed emptying of the stomach. So how do we do the diagnosis of a patient? We look for a diabetic patient with a chronic abdominal discomfort, bloating, constipation. The patient may also complain of anorexia, nausea, vomiting, and early satiety. Diagnostic test. Since diabetes can also be associated with gastroesophageal reflux disease and diarrhea, the confirmatory test includes upper endoscopy or abdominal CT scan that excludes the luminal gastric mass or the abdominal mass that might compress the stomach. But the most accurate test is the bolus of the food that is tagged with the technetium, that is a nuclear isotope. So, a delay in the emptying of the food indicates gastroparesis. So how do we do the treatment? We do the dietary modifications, we blenderize the foods, we restore fluids and correct potassium and glucose levels. If the gastroparesis still persists after dietary modification, so the next step in management is we start a metoclopramide, but we cannot use the metoclopramide for the longer period because they might cause dystonia, dyskinesia, movement disorders in 1% of the patient, other adverse effects that metoclopramide can cause are the long QT and hyperprolactinemia. And if the metoclopramide is ineffective, we give erythromycin or antiemetics. And if all the medical treatment fails, then we go for the gastric electric stimulation or we place the gastric pacemaker. Well, that was pretty much it about the diabetic gastroparesis. Thank you for watching. Meet you in another video.